क्या पता फिर कहाँ है?
We are live, sir.
Okay. So good morning, dear
Rest of the
friends.
day.
This is Sunday morning. We are again here for the next session by Dr. Sahana Srinivas on cutaneous manifestations of systemic disorders. Chairperson for today are Dr. Jalil Ahmed from Coimbatore and Dr. D. Balachandar. Dr. Jalil Ahmed is Central IPEB member from Tamil Nadu, and he is a senior consultant pediatrician and neonatologist at Royal Care Super Specialty Hospital. He earlier worked as chief pediatrician and neonatologist at Sri Ramakrishna Hospital for 34 years. He has been a provider and conducted many workshops. He is active academically as well as in IAP also, and he is an active member of IMA also. So I welcome him. I request him to please introduce Dr.
No,
Balachandran.
sorry, Ajay, I'll just interrupt. I am Alok Bhandari and Mukesh
Welcome, sir.
We are here. You have missed one most important thing about Dr. Jalil, that he is an excellent human being par excellence. I have worked with him in National Neonatology Forum also. Very humble, very polite, sober, soft-spoken, and it is very really difficult to find such a great human being amongst in today's times. So that is the real introduction of Dr. Jalil. And Dr. Dhankar also wants to say him good morning. Good morning, Dr. Jalil and Dr. Bala.
Good morning, sir. Good morning. It was whatever Alok sir is saying, it is
Lost connection. I think.
I request Dr. Jalil to please introduce.
Shall I start, sir? Yeah.
Good
morning, all. Happy Sunday morning. This is my humble and honored privilege to be a part of this program. And I thank the IAP Delhi and Ajay Kumar Gupta, sir, and the President Alok Bhandari, sir, and the Secretary Mukesh for giving this opportunity. And it's my privilege and honor to introduce Dr. Bala from Kerala, who is my co-EB member this year also. Dr. Bala is a senior consultant, General Hospital, Pathinamthitta, is a part of Kerala, and he is a secretary eCCD during 2021 and 22. He is currently an executive board member, served for 2023, and he is a SCAC BNRP Kerala 2022 and 24. Of course, we had a very eventful memories in Kochi this year. He is a joint secretary, National Pedicon 2024, and member of National Advisory Board, IJP 2023 and 28. So he's a secretary of IAP Kerala during the tenure 2019 and 20. He's an organizing secretary of this EnrichCon, convener also. He's an organizing secretary, Kerala Pedicon 2021-3. Dr. Bala is a very humble man. He's a very energetic, and I feel very proud to introduce him. Thank you, sir.
Thank you, sir. Thank you, sir. I request.
Ajay, I will add about Dr. Bala. He is an environmental specialist also. Whenever we think or talk about environmental issues in IAP, first name that comes to our mind is of Dr. Bala and then of Dr. Ramesh Bajania. They are the excellent team who has put in a lot of efforts to make pediatricians conscious of the environmental issues, and it is showing results also.
Thank you, sir.
And Kochi Pedicon organizing team was synonymous with the towering personality of Dr. Bala. Everybody, we had more than 100 strong faculty contingent from Delhi, and everybody had praises for Dr. Bala and the team which organized the Kochi Pedicon. Best Pedicon so far. It was a unanimous opinion of all, and I think Dr. Bala deserves a lot credit for that also. A man with a vast experience and really a great towering personality with keen interest in sports also. And our Dr. Mukesh Dhankar knows him from the sports angle. Sir, sports ke bare mein.
Sir, good morning, sir. So it's our pleasure to have Dr. Jalil and Dr. Balachandran with us today morning. And I also had the pleasure of talking to them yesterday. And I will not take much time, and I'll not come between the topic for today. Over to Ajay, sir.
Thank you, Dr. Mukesh. I request Dr. D. Balachandra sir to please introduce speaker of the day, Dr. Sahana.
Thank you. Thank you very much, sir, Ajay, sir. First of all, let me thank the IAP Delhi team, vibrant team of Delhi, Dr. Alok Bandari sir, Dr. Ajay Kumar sir, and Dr. Mukesh for inviting me to chair this session. It's a very important session on dermatology. Actually, I wanted to attend this. I saw the flyer around 3 months back, 3 to 4 months back, but because of the Predicon and all, during that January season, I couldn't enter this certification course actually. So I'll be happy to introduce our guest speaker today, Dr. Sahana M. Srinivas. She has published a lot of papers, in fact, 98 papers in the national and international peer-reviewed journals. Dr. Sahana has authored at least 38 chapters in various textbooks, and also she has been the awardee of many awards like Vishnu Priya Devi Award for the best original article published in IJDVL last year. Also, she has the best case report published in the online journal of dermatology in 2023. She has been the recipient of reciprocal registration scholarship in last year from the American Academy of Dermatology in New Orleans. And she has been awarded the International Society of Pediatric Dermatology Certificate of Appreciation as faculty member in 17 to 21 and last 21 to 17 to 22, in fact. She has been the recipient of Scholarship Award for 25th World Congress of Dermatology in Singapore as well as in Italy. And she has been the recipient of Developing Country Travel Grant Award at the World Congress of Pediatric Dermatology in 2017 in Chicago, and for the paper of Congenital Chikungunya Rash with Dystrophic Calcification. She is the content editor of IJDVL Clinical Dermatology Review, and also the co-editor of Color Atlas and Synopsis of Pediatric Dermatology 4th edition, which I am proud to have in my personal library. The areas of interest, her areas of interest, genodermatosis, genetic hair, shaft disorders, and pigmentary mosaicism. With these words of introduction, I invite Dr. Sahana and Srinivas for the talk. Over to you, ma'am.
Thank you so much, sir, for these kind words. So I'll just share my screen.
Yes, ma'am. It's visible.
It's visible.
Yes, ma'am. Please.
Yeah. Good morning, all. At the outset, I would like to thank the Indian Academy of Pediatrics, the Delhi group, for this invitation, and also Dr. Ajay Kumar, sir, for inviting me for this certificate course in dermatology. This talk, Cutaneous Manifestations of Systemic Diseases, it is a very vast topic. So I'll focus on few of the conditions where skin can give a clue to diagnose an underlying systemic disorder. I have no conflict of interest or financial disclosures. So as you're aware that many times we see conditions where both skin lesions and systemic disease can go hand in hand. But sometimes skin lesions can present very early, and it can present for many months to years before the actual onset of a systemic disorder. So it's very important for us to have a fair knowledge about these clues, cutaneous clues. So the main learning objectives of this presentation is to recognize the skin signs suggestive of systemic diseases. Early recognition is very important to prevent complications. And many times we see now there are actually cutaneous changes specific to the disorder, but there may be non-specific changes also, and we should be aware of these changes. So as I told you, this is a very vast topic. It's very difficult to, talk about all these disorders at a stretch. But broadly, skin and systemic disease can involve genodermatosis, developmental defects, nutritional metabolic disorders, disorders of pigmentation with malignancy, immunodeficiency disorders, connective tissue disorders, vasculitis, and endocrine disorders. So I'll try to focus on few of these conditions. Now, here's a case scenario. This is a child who presented with, the newborn child only, presented with a mass in the lumbosacral region. So here you can see a well-defined mass. What is this condition? This is a meningomyelocele. So meningomyelocele is an open neural tube defect. So where there is a closure of the neural tube, doesn't close at the lumbosacral region, so causing this defect during the embryonic development. If you see here, you can see multiple tufted hairs at the lumbosacral region. So there's hypertrichosis. We call this as fontanelle. So in another child, you can see here, there is a lesion in the lumbosacral region. You can see where the arrow I'm pointing, there is a vague, very faint erythema. There's a red lesion. This is a portwine stain. That's a nevus flammis. And you can see a scarring here, like a puckered scarring. This is nothing but an aplasia cutis. Aplasia cutis is a congenital defect where there is a congenital absence of both epidermis, dermis, and subcutaneous tissue. So why we should know all this presence of these skin lesions like meningomyelocele, fontanelle, or aplasia cutis and the lumbosacral region? Because they can be the presentation of an occult signs of spinal dysraphism. So whenever you have these skin lesions, we'll have to be vigilant and try to investigate the child for radiological investigation to know whether the child has any other signs of spinal dysraphism. So skin signs of spinal dysraphism, it's an absent or incomplete fusion of midline mesenchymal structure. Multiple cutaneous signs can give a clue to the underlying spinal dysraphism, like fontanelle, which I've already shown, lipoma, portwine stain, sacral dimples, sinuses, which is more than 5 millimeter, hemangioma, skin tag, aplasia cutis, melanocytic nevi. Early detection is very mandatory because it can cause irreversible neurological complications. So it's very important to diagnose it very early and refer appropriately and take management measures to prevent this neurological complications. Now it's also important to assess like whether these lesions on the lumbosacral region really warrants any underlying radiological assessment. So this is a nice article which I got this table. So where you can divide into high risk and low risk. If you see, they have divided this into 3 groups. In group 1, if there is any 2 lesions of any kind or 1 lesion and spinal cord dysfunction, lipoma, fontanelle, or dermal sinus, and if the child is 6 months, it's mandatory to do a MRI. And later also, we'll have to follow up the child by doing an MRI. If it is a group 2, if there are only lesions like atypical dimple, unclassified hematoma, aplasia cutis congenita, or deviation of the gluteal furrow, you can wait. You can do an ultrasound. If it is normal, you don't have to do investigations. After 6 months, you can do an MRI. But if the ultrasound is abnormal, you have to do an MRI. In a group 3, if the only child has hemangioma, portwine stain, hypertrichosis, a simple dimple, or a Mongolian spot, no investigations are necessary. This basically is an assessment when there is only lesion without any neurological or any orthopedic manifestations. Now, this is another case. Here you can see 2 photographs, 2 cases. The first child having a reddish lesion, which is present segmentally. And also the second child, you can see a reddish plaque, which is present on the tip of the nose. So here in the first case scenario, both the children had a flat red lesion at birth and started gradually increasing in size. To see this present, you can see the photograph. So here you can see the first child, you can see a well-defined reddish plaque on the scalp, and you can see the mandibular area, mainly the segmental region. So what is this condition? It's an infantile hemangioma. See, infantile hemangioma is a vascular tumor, and most of the time it presents as a reddish macule at birth and slightly starts progressing. It has 3 phases. It has at birth, it is very flat, and then plateau phase will start progressing, and the maximum progression is up to 9 months of age. And then it starts, maybe sometimes even it can progress up to 1-2 years also, and then start resolving. By 1 year or 2 years, 80% regression will be there. So usually you don't have to worry much about these infantile hemangioma because most of the lesions are benign. But there are some types of hemangioma when they are present at particular sites. You need to suspect there may be a systemic involvement, and appropriately you have to refer and actually start the management immediately. So when we should worry and what are the sites we need to think about, probably the child could have a systemic complication. Like if the child is in hemangioma on the beard area and the neck, probably the child could have an airway obstruction. Periorbital lesion, there could be ocular axis occlusion and more commonly amblyopia and astigmatism. If the child is hemangioma on the lip, perioral region, anogenital, intertriginous area, inevitably these lesions go for ulceration. So they'll be difficult with feeding, micturition, or defecation. Nasal tip usually, yes, it starts growing, but it's more of a cosmetic disfigurement. Large segmental hemangioma can give us a faces syndrome. Lumbosacral region, you have tethered spinal cord, lipomengomyelocele, genitourinary anomalies. And here, otitis, you can have decrease in auditory conduction. It's very important we know if suppose there are more than 5 hemangiomas, that is multiple hemangiomas, you can't just keep quiet. You have to go for a visceral involvement, appropriately get an ultrasound to rule out whether there is involvement of the liver, gastrointestinal tract, because most of the time, multiple hemangiomas on the skin can also have hemangiomas, most commonly in the liver. And sometimes they can give rise to congestive cardiac failure, hypothyroidism also. So it's very important that any hemangioma present on these sites, we should be very vigilant and actually investigate the child very deeply and also start the treatment immediately. Now, here's a case scenario. There's a 2-year-old female child who had recalcitrant anemia. She had multiple transfusion. The child also had thrombocytopenia and bloody stool in the past 1 year. So this was referred to me by the pediatrician for this persistent anemia, and he had noticed these lesions on the trunk and extremities for which I was referred. So if you can see here, this child is multiple bluish, dark pigmented, soft papular lesion on the trunk. You can have a large, soft swelling on the palms. This is nothing but a case of blue rubber bleb nevus syndrome. So when this is a venous malformation, and this venous malformation is not only present on the skin, but it can involve even the GI tract and visceral organ. This is the main reason for the child to have this persistent anemia, thrombocytopenia. So sometimes if you are not able to understand this, we may have to treat the cause of anemia as a different cause. So it's very important to recognize the syndrome because they are all very recalcitrant to treatment. And sirolimus is only the main management in these patients. Now here's a child where you can see hyperpigmented lesion. There's a pattern type of pigmentation in both the cases. But if you see, they're all linearly arranged pattern on the lines of Blaschko's. So whenever you see a child presenting with the hyperpigmentation along the lines of Blaschko or like archetypical patterns that I'm showing here, these are the archetypical pattern of skin lesions. They are divided into many types. Here, type 1A is a lines of Blaschko, this narrow band pattern. And the type B is a lines of Blaschko broad band pattern. Type C is a checkerboard pattern. Type D, type 3 is a pilot pattern. Type 4, you can see if the lesion doesn't cross there's no midline separation. And 4, we have a lateralization, and type 5 is a sash patterns. So whenever you see this pigmentation on these lines, you'll have to think about pigmentary mosaicism. So what is this pigmentary mosaicism? It's nothing but it is a pattern type of pigmentation. And before they used to call this as hypomelanosis of Ito, linear nevoid hypermelanosis, but everything is clubbed under this umbrella term called pigmentary mosaicism. This pigmentary mosaicism is not just related only to skin pigmentation. Most of the time, 50% of the time, it is only cutaneous involvement, but in 50% of the time, it can involve extracutaneous involvement. So the most common involvement is a neurological. So many of the child is referred from neurologists for seizures, developmental delay, and there's no cause for this seizures. But that time we need to think about this pigmentary mosaicism. So the other system which can be involved is muscular system, ophthalmic, cardiac, renal, gastrointestinal, endocrine, and many other systemic involvement will be seen in this condition. Here you can see 2 case scenarios. The first child, you can see multiple small to large pigmented, large brown pigmented macules. Some are small lesion, some are less than 5 millimeter, some are more than 5 millimeter. And this is a child born of non-consanguineous marriage. And what are these lesions? They are nothing but capillate macules. So this is another child who has a large pigmented, that is brown macule on the segmental area. So this is also a capillate macule, but it is seen in Macunet-Albright syndrome. Why we should know capillate macules? Capillate macules are the skin markers for underlying genodermatosis. It can be present in neurofibromatosis, tuberous sclerosis, Menk type 2B, Gauchers, and many other conditions, Glute syndrome, ataxia telangiectasia, and many other systemic involvement, and mainly the genodermatosis. But if you see this type of segmental capillate macule in a child, we should think about Macunet-Albright syndrome. There's a lot of difference. If you see the first case, it is a well-defined, very smooth borders. Here you can see there is well-defined but the serrated border. So it's very important to differentiate a capillate macule of various other conditions with the capillate macule of a Macunet-Albright syndrome. In a macular Albright syndrome, the capillate macules are larger, they are patterned, they're dark brown, jagged margin, which is also called as a coast of Maine. But in a neurofibromatosis, when you see a capillate macule, they're smooth borders, they are called as coast of California. Why we should know this? Because they always present an underlying polycystic fibrous dysplasia, precocious puberty, and many endocrine abnormalities like hyperthyroidism. So it's very important to recognize these capillate macules, the pattern of the capillate macules to recognize the systemic disorder. Here you can see a child presenting with multiple hyperpigmented, almost I can say blackish, small pigmented macules on the lips. So what are the differential I would consider? Whether it is a freckle or it's a nevi or it's a lentigen. So a freckle is something with a tan brown macules, mainly on the exposed part. But usually lentigens are very tan, small pigmented brown macule, and they are mainly present on mucocutaneous junctions. So mucocutaneous or mucocutaneous lentigen. Why we should know this mucocutaneous lentigens? Because there could be a part of Peutz-Jeghers syndrome, Carney complex, or a part of the PTN hematoma tumor syndrome. Now, how do we approach this case whenever you see a case of mucocutaneous lentigens? Now, a child comes to with a mucocutaneous lentigen, ask about, see the distribution, ask about the family history and associated medical condition. Now, if there is lentigens on the lips, conjunctiva or a genital lentigens, and if you investigate for hematomas or polyps in GI tract, you can diagnose this condition as Peutz-Jeghers syndrome. If there is lentigens on mouth, lips, fingers or toes, along with cutaneous myxoma or blue myxoma, there could be systemic involvement like cardiac myxoma, breast myxomatosis, myxomatosis, Cushing syndrome, acromegaly, osteochondromyxoma. That indicates Carney complex. If the child has lentigens along with skin tags, acral keratosis, papillomatosis papules, you should investigate the child could have breast thyroid cancers, endometrial cancer, macrocephaly, intestinal polyps, lipoma, fibroma. Think about PTN hematoma syndromes. You see, this is a child presented with skin lesions from birth. It's small, but the child was quite active. No developmental milestones are normal. This is around 11-year-old child, but the child had hoarseness of voice. So, and this was referred to me for the skin lesions. So when you see the skin lesion, you can see multiple papillar lesions on the forehead. You can see on the cheek. You can see on the chin. Along with the child also had this very thick tongue, that is macroglossia, thick lips also. So I'll just put a closer view. Here you can see this child had some lesions on the eyelid margin. This is the beaded papules. And mainly this is a condition called as Lipoid proteinosis. So Lipoid proteinosis, it is an autosomal recessive condition. It is usually present due to deposition of a hyaline material in skin and multiple organs. It can involve respiratory involvement, neuropsychiatric abnormalities, and most commonly the child would have hoarseness of voice and facial scarring, the photosensitivity. Because of that photosensitivity, the child develops multiple papillar lesions and scarring on the photoexposed area. And also that beaded papules, which I showed in the photograph, is a very characteristic feature of lipoid proteinosis. Whenever you have a child present with these facial scarring, papillar lesions, beaded papules with hoarseness of voice, start investigating the child in terms of lipoid proteinosis, because the child could have other issues like gastroenteritis bleeding and dysphagia also. So I think this is very, almost many of the pediatricians see these cases. This is a child who presented with these skin lesions referred to me. But along the skin lesions, what you can see, the child had a very dry skin, a wrinkled skin, loss of subcutaneous fat, loss of muscle mass, a lot of wasting. The child is looking a lot of cachectic and a lot of scaly plaques in the trunk. The child is alert. Yes, I think you've already guessed this case. Is this a child with marasmus? If you see this is a child with edematous lesion. This presented with facial edema, edema of the, you can see the abdominal swelling, and along with other multiple cutaneous features. So when it's referred to me, the cutaneous features, the child had moon's faces, scaling, a lot of hyperpigmented macules on the face. You can see on the chest, on the trunk, a lot of scarring also, depigmentation. Apart from that, you can see the cheilitis, and also the hairs are very dry, brittle, hyperpigmented hair. So whenever you have these presentations, you have to think about kwashiorkor. So if a child presents to with periocular or perinasal, perioral or perianal dermatitis, periorifacial dermatitis or perianal dermatitis, what are the differential diagnoses you think about? One thing, diaper dermatitis. Yes, I think is most commonly whenever we have a child with diaper rash, perianal dermatitis, the first differential would be diaper dermatitis. But diaper dermatitis usually it doesn't occur on the periorifacial or perioral. It's very unlikely. It's only restricted to diaper region. And primarily, this is a primary irritant contact dermatitis, not the diaper, but because of the urine and the feces. And usually it involves the diaper region, but the inguinal fossa will be spared. Perianal lesions can also be involved, but very less commonly. So very unlikely this child to have a diaper rash. So another differential diagnosis which we could consider is a zinc deficiency acrodermatitis enteropathica. So it's a triad of dermatitis, diarrhea, and a dementia also progressively, and then progressively the child can have also other complications. So here, acrodermatitis enteropathica presents classically with periorifacial and perianal dermatitis, a persistent lesion, and probably it will be secondary to probably breastfeeding children or early weaning, and because of the malabsorption also. And another deficiency is biotin deficiency. So biotin deficiency can also present as perioral, orifacial perianal dermatitis. But in biotin deficiency, neurological involvement is very common rather than zinc deficiency. And if you see in zinc deficiency, child is probably not having other systemic features apart from diarrhea. The neurological complications more in biotin, and even the hair changes are very common in biotin deficiency, loss of hair. So whenever you see these conditions, you need to think about these differential. Kwashiorkor also, which I've already shown, and Kawasaki disease. But this is a child having persistent lesions from a longer time. So very unlikely to think about a Kawasaki disease. I'll just show the photographs. Yeah, Kawasaki disease, I think almost all pediatricians keep seeing this cases regularly. Child present persistent fever, and then presence of cheilitis and perianal rash and diaper rash. But there's usually an erythema. But along with the rash, they also have a periangual desquamation. You can see here the periangual desquamation. So any child presenting with persistent fever, having cheilitis, always strip the child, see the child for perianal rash, and also see for the periangual desquamation. Inevitably, it's a diagnosis of a Kawasaki disease. Now, here's a child who has diaper rash. But what is the type of rash you're seeing here? It is not the usual diaper, the lesion you're seeing. So you can see here the multiple tiny, there are purpuric lesions in the diaper region. So whenever you see a purpuric lesion in the diaper region, definitely you should think about a systemic disease. It is not something just related only to the cutaneous skin disease, only a dermatologist point of view. It has a very serious implication. So this child also had these purpuric lesions, that is the papules and the eroded papules on the scalp. The child had purpuric macules on the abdomen, on the palms. You can also see a bit of hypopigmentation on the back. So whenever you see a persistent diaper rash, diarrhea, failure to thrive, not responding to therapy, always think about Langerhans histiocytosis. It is a neoplastic histocytic disorder which can affect the skin and multiple underlying disorders like liver, spleen, bone marrow, and systemic involvement in the form of fever, failure to thrive, respiratory distress, pneumonia, hepatosplenomegaly, and various hematological involvement. So what are the cutaneous clues to diagnose this case as Langerhans histiocytosis? Any child presenting with persistent diaper rash, not responding to treatment. If you see a purpuric lesion, see an eroded papules in the inguinal fossa, seborrheic dermatitis distribution, or a scaly red papules, vesicopustules, crusting, or a chronic paronychia which is not responding to the medical lines of management, always think that their child is having systemic disease and Langerhans histiocytosis. Any child will have to rule out Langerhans histiocytosis, get a biopsy done. This is another child with a purpuric lesion in the extremities. So here the purpuric lesions were very palpable. This is called palpable purpura. Whenever you see a child with a palpable purpura or with any systemic symptoms like fever, arthritis, abdominal pain, two differentials you have to think about is enox-condyline purpura and leukocytoclastic vasculitis. How do you differentiate? Both the conditions present with palpable purpura, but enox-condyline purpura is seen more commonly in children, And they are more common with systemic involvement, more with renal involvement, abdominal involvement, that is GI involvement. Leukocytoclastic vasculitis is only cutaneous involvement. So whenever you see a palpable purpura, so think about Henoch's corneal purpura in a child. This is a child presented with progressive symmetric pigmentation of the extremities. Here you can see ill-defined pigmentation on the lower limbs. You can see this pigmentation on lower limb. So whenever you see a child present with progressive pigmentation or a generalized pigmentation involving even the palms and soles, so what are the differential diagnoses you think about? Addisonian pigmentation, Addison's disease, or in Addisonian you can think about iron deficiency or vitamin B12 deficiency. And something when suppose a child is very small and generalized pigmentation, you need to think about endocrine congenital adrenal hyperplasia also, and sometimes syndrome like Fanconi syndrome, Fanconi anemia also can present with generalized pigmentation. So investigate the child. Serum vitamin B12 and serum cortisol is very important because this child had vitamin B12 deficiency. So what are the skin manifestation of vitamin B12 deficiency? I think nowadays we are seeing a lot of vitamin B12 deficiency in children. Even they come with even hair fall also. But the classical presentation is symmetrical, generalized hyperpigmentation, commonly involving the flexural, palmar crease pigmentation, soles, and even the knuckles, but some can become into a generalized pigmentation also. Glossitis, red beefy tongue, cheilitis, after-like lesions, and you can also see pigmented streaks on the nails and premature graying. I think now even we are seeing a lot of cases with premature graying. So the first thing, nutritional deficiency we'll have to think about, and the most common will be vitamin B12 deficiency. Now, Addison disease. Addison disease, also similar to vitamin B12 deficiency, can have symmetrical hyperpigmentation, but they're more common in the sun-exposed area. Of course, the flexural sites and the pressure areas, the frictional areas can be involved. But more than vitamin B12, the creases will be pigmented in Addison disease. And even as I said, nails, genitalia area will be pigmented. There will be conjunctival pigmentation, oral mucosal pigmentation, gingival pigmentation. And as I said, this is a cause of the generalized pigmentation. Now, immunodeficiency, when to suspect a child with immunodeficiency? When a child has severe pruritic erythroderma. What is an erythroderma? Whenever a child presents with diffuse erythema and scaling all over the body, presenting more than 80% to 90% of the body surface area is called erythroderma. So one of the most common cause of this erythroderma in children is immunodeficiency. And recurrent abscess, we have to suspect immunodeficiency, recurrent bacterial infections, atopy with pedicle Viscott-Aldrich syndrome, severe alopecia, or abnormal hair color dysplasia, we'll have to think that the child could be having immunodeficiency and investigate appropriately. Now, I put a photograph of a child with neonatal erythroderma. This child was born of consanguineous marriage and present with erythema and scaling all over the body and investigated appropriately. So, and this child was a case of actually Netherton syndrome. It's also an immunodeficiency. But in one study, they found that 30% of the cases of erythroderma, the cause is immunodeficiency. And 24% is ichthyosis, and in 20% it is inflammatory dermatosis. So I would like to say that in erythroderma, do not miss investigating the child with immunodeficiency. Now, there are some certain clues, cutaneous clues, which can probably diagnose a particular type of immunodeficiency. If it is a severe combined immunodeficiency, the child will have recurrent infections, but the child can have pyoderma, seborrheic dermatitis distribution, erythroderma. Omen syndrome, there is erythroderma along with diffuse alopecia. In Netherton, there's erythroderma and there is a cutaneous lesion, which is called as ichthyosis linearis circumflexa, psoriasis plug with the double-edged scale, atopic diathesis, and hair dysplasia. That is the most common presentation is trichorexis invaginata, trichorexis nodosa. In DiGeorge syndrome, the child is erythroderma along with mucocutaneous candidiasis and pigment disturbances. In Viscott-Aldrich, the characteristic cutaneous clue is the purpura, the pedicle lesions. The child will have eczematous lesion, just like an atopic dermatitis. The child has recurrent infections. The child will have pneumonias. But when you closely look at the cutaneous lesions, the pedicle lesion gives a clue that probably child is not just having an eczema, but an underlying immunodeficiency. And that is a clue for Viscott-Aldrich syndrome. GVHD, like morbilliform rash, epidermal sloughing, or erythroderma. Hyper IgE syndrome, also you have multiple abscess, severe dermatitis of face and scalp, along with sinopulmonary abscess. So this is a child with GVHD. You can see the epidermal sloughing, and other cutaneous lesions of acute GVHD could be confident erythema, morbilliform rash, intense pruritic lesions, exfoliative erythroderma, and toxic epidermal necrolysis. Now here's a child presenting with fever, with a rash on the face, as well as painless ulcer. So if you see, when the child was referred to me, you can see this. There's a child has a skin lesion on the face. What you can see is there's a well to ill-defined rash, that is the erythematous scaly plaque, and they are seen on the what region? It is a malar region. Some lesions over on the forehead. The child has erosion on the lips. Whenever you see a rash that is a malar rash, that is which is called as a fixed erythema, flat or raised over the malar eminences bearing the nasolabial fold, the first thing differential you need to think about is a systemic lupus erythematosus. So, and investigate the child appropriately. Here is a child. You can see a malar rash. So you can see here there is a well to ill-defined, about a bit of violaceous macule on the malar region. But what you see in this child is also the child also has violaceous a bit of pigmentation on the chest and upper arm. So the upper trunk is involved. So this child, closer view, you can see the upper eyelid also. There's a violaceous erythema on the upper eyelids. There's a heliotrope rash. There's a diffuse violaceous erythema with pigmentation on the, this is called as a shawl sign, and also multiple papular lesions on the phalanges. You can see this is a Gottron's papule. So even in this is a child with dermatomyositis. Both SLE and dermatomyositis can have a malar rash, but in dermatomyositis, you have to start seeing the upper eyelids, you have to see the dorsum of the hands, you have to see the upper trunk. For these skin lesions like heliotrope rash, shawl sign, Gottron papules are the cutaneous clues for dermatomyositis. Now, not only the skin lesions, even the hair lesions can give a clue for an underlying systemic disease. Now, here I have put two cases. What is abnormal in this child? Of course, the hair is definitely not normal. So you can see the silvery sheen hair on the scalp. You can see even a bit of eyebrows also were silvery sheen. I've just masked it. So whenever you have a silvery gray hair, start thinking about silvery gray hair syndrome. There are three types of silvery gray hair syndrome: Grisseli syndrome, Chidiac-Higashi, and Ehlers-Danlos syndrome. Now they say that Ehlers-Danlos syndrome is a part of Grisseli syndrome only. So how do you differentiate the two more important underlying silvery gray hair syndrome, which are the immunodeficiency syndrome, that is the Grisseli syndrome, and the Chidiac-Higashi syndrome? So both can present with a lot of systemic involvement, like hematological involvement and recurrent infections and pneumonia. Simple hair testing can give a clue. In a Grisseli syndrome, take the hairs, examine in the microscopy, you can see these pigment clumps. Small and large pigment clumps present irregularly gives a clue to Grisseli syndrome. When you examine, see a very small regular pigmentation of pigment clumps, regularly arranged pigment clumps, you think about Chidiac-Higashi syndrome. In Chidiac-Higashi syndrome, hematological complications are more common. Grisseli syndrome, neurological complications are quite common. In Chidiac-Higashi, apart from the hair clues, even the peripheral smear, large granules will be present in the leukocytes, which can give a clue for you to diagnose Chidiac-Higashi syndrome. This is very important because this can progressively deteriorate, and also sometimes you may have to have bone marrow transplantation. I think all of you know this. This is just a spotter case. Child present with the depigmented macules on the face, and you can see on the chest, also the trunk. So this is a case of vitiligo. So is just a vitiligo just a cutaneous disease, no systemic involvement, it's just a cosmetic concern? Yes, probably it's a cosmetic concern, but we should think about that. It could be a sign of systemic disease. It can be associated with other autoimmune conditions like diabetes mellitus, hypothyroidism, Hashimoto's thyroiditis, Addison disease, inflammatory bowel disease, autoimmune polyendocrine syndrome. And also in 66% of the cases of these vitiligo, many of the children had uveitis. So it's very important that we also should regularly monitor the child, not only for other endocrine abnormalities or autoimmune conditions, but also regularly you have to refer them to ophthalmologist to rule out uveitis. And there could be fundal pigmentary abnormalities. Even I do have seen cases where the child has developed even deafness, sensorineural deafness because of vitiligo. Now, this is a child, you can see this bluish, well to ill-defined bluish macule, and this is persistent. This is a persistent large Mongolian spots. So here you can see a child with present with multiple papillar lesions, and if you can see the arrangement, they're almost like a pebbled appearance, like a rippled pebbled appearance. So whenever you see this persistent Mongolian spot or pebbling of the skin, it could be an underlying factor for MPS. Pebbling of the skin is a very characteristic feature of Hunter syndrome. Now, this is a child who had seizures, and the child was put on anticonvulsants, phenobarbital. So after 6 to 8 weeks, the child's developed erythroderma. You can see here, diffuse erythema is there, scaling all over the body. So inevitably, this is a case of drug reaction, drug hypersensitivity syndrome. It's also called as drug reaction with eosinophilia and systemic symptoms. Why I'm putting this case of drug reaction is because now this DRESS syndrome is not just related to a drug reaction. Long-term follow-up is very necessary because we have seen that in a study, a 1-year follow-up of these children who have developed a DRESS have developed multiple autoimmune diseases. And but these children also, as they start aging, they have developed into end organ failure. So end organ failure can be common in elderly patients, but in children, invariably, they tend to develop autoimmune diseases. So whenever you see a child with drug hypersensitivity syndrome, you have to follow up the child regularly for other autoimmune diseases. Now, this is a 11-year-old male child who presented with fever. Child had sepsis, and you can see this well to ill-defined purpuric macules. They are very deeply ecchymotic lesions, I could say, and with the surrounding erythema on the face, you can see the ecchymotic lesions on the lower limbs. This is nothing but a purpuric lesions, the large purpuric ecchymotic lesions. But a child with a fever, with a purpuric ecchymotic lesions, or purpura or necrotic lesion at birth, you have to think about neonatal purpura fulminans. It's not just because of any sepsis, it could be a deficiency of protein C or S deficiency. So when you recognize this condition, it will be easy for us to treat this child. Now, this is a child who has this skin lesions on the peri-orbital region and also multiple lesions on the upper limbs. So what you can see is well-defined plaques, but if you see the lesion, they are yellowish plaques. On the persistent, they are yellowish plaques there. So whenever you see this yellowish plaques on the periocular region or in other areas of the body, even in the joint areas, is a clue that this child has xanthelasma. Why we should know this case? Because xanthelasma is not just a cutaneous problem. It's not just only dermatologists will treat this condition, because it can indicate an underlying familial dyslipidemia, more commonly seen in type 2A, type 2B, as well as type 3. So these are the cutaneous clue, which can immediately give us a clue that it could be a part of an underlying systemic disease. So I would like to give some take-home messages that knowledge of any associated dermatological features is very necessary, because most of the time we may have both typical lesions or atypical lesions, persistent lesions, and they should always raise a suspicion of an underlying systemic disorder. And if suppose lesions are not responding to therapy, also should indicate the underlying any malignancy or any other systemic disease, because organized team approach is also very much necessary. So skin is a mirror to underlying systemic disorders. Thank you.
Thank you, ma'am. Your presentation was very enlightening, and it was very well presented. And I think it answered every query, because there is no question on the question answer board.
Thank you, Dr. Sahana. It was a very wonderful presentation. As truly you said that skin is the mirror of the body, and actually it's a window through which we can see all the systems of the body. So early diagnosis, if you the greatest system, that is the skin, which can reveal the secrets of the body. So if you can early manifestations, if you find out, you can diagnose and can give the prognosis and manage the disease. So it was a wonderful presentation. One small doubt is that this acanthosis nigricans. You had presented one case of acanthosis, which showed a picture of acanthosis nigricans. Sorry, that acrodermatitis enteropathica. Which other areas are affected in acrodermatitis? Is it only the dental and buttocks area, or?
Mainly the periorifacial area and the perinasal region, perianal dermatitis, and even the diaper region also. But it can also involve the extensor aspect of the upper limbs and lower limbs. It's not just the periorifacial, even other areas also can be involved. Mainly the acral areas only. Acrodermatitis, the name itself gives that it is an acral areas.
You give zinc for 14 days.
Yes.
Zinc. You give 20 milligram.
No, it is zinc. Suppose if an acrodermatitis enteropathica, we'll have to give lifelong. It is a zinc deficiency, 50 milligram, elemental zinc, 50 milligram per day is necessary.
50 milligram even for children.
Yes, sir. Even for children we give. Because it won't resolve. Because I've seen cases with different morphological pattern, acroderm bullous form, or even the lichenate form, psoriasis form. So as soon as we stop the treatment, the child starts developing the lesion. So lifelong, the child should be given, especially if it is a congenital acrodermatitis enteropathica, we should give for lifelong the zinc supplements.
And any side effects if you give lifelong with high dose of zinc?
I have not seen anything. But I think minimum elemental zinc is 50 milligram. But I have the higher doses probably, but I have not seen any side effects.
Maintenance dose is 5 milligram and we give for diarrhea 20 milligram. This is 50 milligram.
50 milligram is for zinc. For biotin deficiency, you can definitely give biotin. 5 milligram, 2.5 to 5 milligram.
Thank you, Dr. Sahana, for your excellent presentation. And skin, the largest organ in our system, and it is a gateway to identify any serious hidden disease. So from your flow of presentation, we as a pediatrician understood that is the early diagnosis and intervention is mandatory, pickup rate is high when you know the skin manifestation in all the systemic diseases you have mentioned. There is recently I read one regarding the acanthosis nigricans. Many patients with obesity, this month is obesity month. So even during the interaction, I always see the acanthosis nigricans as a part of counseling. It means, as Dr. Pala mentioned about, it is an insulin resistant marker. It's a surrogate marker of insulin resistance. As a part of counseling, do we mention about this acanthosis nigricans to the parents or the patient for the future chances of developing insulin resistant diabetes? Is there a confident message to the parents during counseling, madam?
So not all cases may develop insulin resistance, but whenever you have an acanthosis nigricans along with skin tags, both when you have skin tag, that is a clue. Probably the child may have high chance of developing insulin resistance. But usually it could be just benign familial obesity. They can have acanthosis nigricans. So it's not like mandatory that all cases with acanthosis nigricans will develop into insulin resistance, the diabetes. No. So
will it disappear over a time of?
No, sir. No. So
that's what I'm asking.
No, definitely the acanthosis nigricans will not resolve completely. So even with lifestyle modification, with treatment, with topical medications, whatever we give, there is improvement of 30 to 40% only. So 50% it usually remains, but gradually I would say 40% would still remain. So none of the lesions will resolve completely. That will have to counsel the parents that it's going to remain for a longer time and throughout the life.
And again, for the hyperpigmentation in Addisonian disease and vitamin B12, and these lesions slowly disappear once the replacement done. They will, I have seen B12 deficiency with knuckling, hyperpigmentation and all, they will disappear.
Yes. That disappears, but it takes a long time, 6 months to a year. So sometimes when we see these children admitted in PICU, when they come to us with this vitamin B12 and Addison's disease, we are so surprised to see this is the same child after 1 year because all the pigmentation resolves. But it takes a longer time.
We'll take the questions, Dr. Bala, please.
Yeah, but there are questions in the chat box. One more question, ma'am. Why vitamin B12 deficiency is increasing? You said that B12 deficiency is increasing nowadays.
So, but I'm not sure because I think I do first time I asked them whether they are vegetarians or non-vegetarians. But most of the non-vegetarians also have vitamin B12 deficiency. So invariably,
It is proved the B12 only present in non-vegetarian source. There is no vegetarian source for B12. Dr. Bala, please go through the questions.
Questions.
Question answer.
yeah. So can you?
Yeah, there are some questions now.
Sorry, I lost some issue in the internet. So
No, it's okay. Please, one Dr. Jarna K. Doshi has asked, please advise on B12 syrup brands. B12 syrup.
there are many other brands. I think we just have to give vitamin. I just refer to
There is-
pediatricians. I can't tell the brand's name. I think the pediatricians
To
only
my,
can.
to my knowledge, there is no B12 brand. We have to take the parental form.
Yes, exactly. So I think it's a combination. So I'm not aware of only vitamin B12.
The combination is not suit with the requirement, actually.
Okay, okay.
In case of deficiency, you have to go for parental.
Oral medications are
It always with you have the cyanocobalamin syrup. Yes, Dr. Ballard. One more question.
One more question. Treatment of pseudoacanthosis, differentiating point from acanthosis nigricans.
It's very difficult to differentiate clinically between pseudoacanthosis and acanthosis. It's a part of acanthosis nigricans is nothing but hyperpigmented, hyperkeratotic, velvety appearance on the neck, flexural areas. But only we have to get the investigation and see the cause of the acanthosis nigricans. So if suppose there is no cause, we call this as probably a pseudoacanthosis nigricans. So we usually give keratolytic agents, mild like urea-based you can give around 10 to 12%. Short contact therapy can be given, or even normal emollients also can be tried.
Okay. There are no more questions here. Some of the questions, yeah. If hemangioma is not responding to propranolol, what should be our strategy?
Actually, in my experience, I think there's no case which is not responding to propranolol. So there's no propranolol resistance at all. Either we'll have to see whether we are properly dosing it. So because we'll have to start at the proper dose, not at the low dose, 2 to 3 milligram per kg body weight. And we start decreasing when the skin lesions start resolving, that is start decreasing. But we should appropriately see the weight of the child. So we always keep it the same dose. So we'll have to see the weight and then appropriately dose it. I don't think so there would be any resistance to propranolol. But there are some studies where they have given atenolol because propranolol causes this sleep disturbances. They get across a blood-brain barrier, but there's not much evidence to start atenolol in many still, but propranolol is giving good results. You can add a bit of steroids also, oral steroids, but I have not tried oral steroids in hemangiomas. And beautifully propranolol resolve. I have tried.
Even for systemic hemangioma, like hepatic hemangioma, this is oral administration of propranolol is very well work.
Yes, it works very well. So I have not.
But only thing, those conditions, this baby may require hospitalization in order to watch for sugar. They will go for hypoglycemia and rhythm dependence.
Yes, so initially a few years back when this therapy started, we used to always admit the child. But now if the patients are educated, and normally times they are doing an OPD basis, even in home basis also. We are not, we are just trying to tell them to feed the child immediately after giving propranolol. So many times hypoglycemia is not given much, it's not a complication at all at this point of time after many years.
Yeah, yes, ma'am. How long we have to wait for propranolol for the effect?
So usually it is very fast effective. At least by 3 to 4 weeks only, it starts showing the results. Even, I must say, even ulcerated hemangiomas, within 2 weeks only, it starts showing the effect. But you'll have to give it for a prolonged period, up to 1 year, 2 years also. I have patients who have given up to 3 years also. Because 80% will resolve only by 2 years. But the 20% slowly it will be regressing. So once after 9 months, we feel that, yes, it is resolving and you stop, there'll be a relapse. So prolonged treatment is necessary.
Okay. And
Madam, what is your experience with the topical application like Timelol for
Timolol.
the local?
So my experience is not good. It's not that very effective. But suppose small lesions, you can try giving timolol. But for not for other, I think the functional impairment areas, I think we should try oral only.
another question is, what is the treatment for premature graying of hair?
So I think we should know the cause of this premature graying of hair. It's very difficult for us also to treat actually. So if there is some cause of iron deficiency or vitamin B12 and their cause, we'll have to treat appropriately. But I think it's just nutritional only. There is no one treatment for this premature graying.
Only we have to find out the cause, whether there's
Cause.
hypothyroidism or anemia. Like.
Yes.
There is a myth. Recently, I came across one baby. Suppose couple of hair, gray hair is there. Of course, we are going to prescribe zinc or vitamin B12, whatever it is, or multivitamin as a placebo. By pulling the affected hair, will it increase the number of further graying?
No, sir. It's actually
The mother was asking to me.
It's a myth, sir. It's definitely a myth.
It's a myth only. So we have to counsel.
Counsel, yes.
This chronic constipation is it one cause for premature graying?
I'm not.
Not
I'm
sure.
not sure about it, sir.
Folic acid deficiency, anemia, hypothyroidism, all these are causes.
Possible, yes.
But
Vitamin B12.
Stress and anxiety can produce premature graying.
I don't know how because there is not evidence much base for stress and anxiety levels. Possible, but I don't think, I'm not sure about it. Because nowadays for all cutaneous lesions for any skin, always stress and anxiety is always given as one of the cause.
Using dryers, no, will it cause premature graying?
No, sir, definitely no. It's a myth.
So the message to the viewers, majority of the cutaneous manifestation, we as a pediatrician concentrate on infection and inflammatory diseases. There is also, as the madam mentioned about the systemic diseases of various systems like endocrine and GI tract, neurological. This a practicing pediatrician should at least have the high index of suspicion when they spot one skin lesion. They have to attribute it to the underlying skin. Say, for example, capillary spot or the Sharon patches, everything. They are usually they'll have the underlying systemic diseases. As a pediatrician, you should know this. This is a very important discussion on cutaneous manifestation to identify or diagnose the hidden systemic disease. Thank you very much.
Ma'am, there are two more questions. One is, can you repeat the difference between diaper dermatitis and contact dermatitis?
See, diaper dermatitis, when we say it's a primary irritant contact dermatitis. So it's not because of the contact, because of the irritation, because of diaper. It's mainly because of the prolonged contact with the urine and the feces. So what happens in the actual diaper dermatitis, the inguinal fossa will be spared. But in other, suppose if it is a candidial, diaper dermatitis can go for a candidial infection or many other dermatoses can be involved. So that diaper region will be involved. If you see a maceration in the inguinal fossa, if you see some eroded papules in the inguinal fossa, you start investigating. If there are peripheral pustules, satellite pustules or peripheral scaling along with inguinal fossa, then it could be diaper rash with candidial infection. If that is spared, it's only a primary irritant contact dermatitis. If there's purpuric lesions and eroded papules in the inguinal fossa, we'll have to think about other systemic disease like Langerhans and histiocytosis.
Ma'am, we have got 10 more questions, so we'll go fast. We are rapid fire.
Okay.
Niacin deficiency versus eczema.
I didn't get you, sir.
Niacin deficiency versus eczema. How will you differ?
So actually, I think in niacin deficiency in eczema is just only skin lesions, but in niacin you have the cheilitis, you may have nail changes, glossitis, you can have some hair changes also, which is very unlikely to be seen in eczema.
We get the 3Ds in niacin deficiency, no?
Yes. Diarrhea, dementia.
Dementia. And
Dermatitis.
Yes. Any investigation for acrodermatitis enteropathica?
That is only thing serum zinc level should be done. That is given. Otherwise, for congenital, you can do genetic testing.
Okay. So in a 6-month-old baby having colostomy with a recurrent itchy papular rash, macular papular rash, is there any relation?
So if there's a colostomy and if there is a reaction there, persistent reaction, probably an irritant contact dermatitis, and it gets secondarily infected, as a form of id reaction, probably other areas can be involved. If it is a chronic. So, but you should see the skin lesions, the morphology skin lesions to give a differential diagnosis for that.
Okay. We have come across a lot of B12 gummies online. Are they helpful?
I think I have no idea about this. I think I do heard about a lot of gummies, but I think I do not prefer it.
Yeah, and the dose is also very important. Do depigmentation creams work in acanthosis nigricans?
No, none of the depigmenting creams work. It's only mainly keratolytics, that urea content you can give, which is possibly help in decreasing the acanthosis.
Okay. The scalp hemangioma, timolol eye drops better or propranolol?
Scalp hemangioma depends, because when it's in the unilateral scalp, it is a part of segmental. If it is more than 5 millimeter also, we'll have to do an MRI and see. It's only less than 5 millimeter. There is no other involvement. You can try, but they are only usually slowly progressing. So you have to start with propranolol. But some cases, depending upon the size of the lesion, you can start timolol. But I would prefer propranolol.
Okay. Duration of propranolol treatment for hemangioma? Till it's
up to 2 years. Minimum 2 years. Yeah, till 2 years.
Duration of oral propranolol for hemangioma, same question.
Yeah, same thing. You start at 2 milligram per kg body weight. And slowly you can increase it and slowly then decrease it up to 1 milligram per kg body.
You give once daily or divided dose?
In divided doses you can give. 3 divided doses.
3 divided doses. 2 to 3 milligram per kg per day in 3 divided doses.
Doses, yes.
Okay. A child presented.
Yes, Dr. Ajay Kumar sir has raised hand.
But sir is not in the panel.
Ajay Kumar sir has raised.
Okay, we will have.
Go ahead.
We have 2 more questions only. A child presented with frequent oral ulceration, improving on vitamin supplements and oral gel. How to approach and manage?
So what oral gel? It depends upon, like, if suppose the child has candidiasis, then we'll have to apply. If you give a treatment, then you'll have to apply appropriately. Candidial paints are available. Mouth paints are available.
Oral ulceration means it might be abscess ulcers.
So after ulcer, yes, you can have, suppose only plain, you can give topical steroid gel base, ora base is available. So you'll have to apply by using a Johnson bud.
Will vitamin B complex deficiency produce abscess ulcer?
Yes, it can produce.
Along with iron and nutritional.
Yes, nutritional deficiency should be ruled out.
Maybe that is the only reason in children. In adults, we see abscess ulcers related to stress and all. Traumatic also is seen in children. Stress. Then last question, hemangioma over the nasal bridge. What to do? How to approach?
Immediately you'll have to start the treatment with propranolol, sir. You can't wait for it because it starts progressing and it may cause sometimes not much of ulceration, but still it becomes a cosmetic disfigurement. So early treatment is very necessary. Some of the sites, when I told you that showed the photograph of the table, functional impairments area, some cosmetic disfigurement area, immediately you have to start the treatment.
Okay.
So thank you, Bala. We'll wind up. Ajay, I have another session in cardiac masterclass.
Okay, we'll wind up, sir.
Ajay? Yeah, go ahead, Bala.
So, shall we wind up with a vote of thanks? Jared, sir?
Yes, sir.
So, we had a very wonderful session on cutaneous manifestation of systemic diseases by Dr. Sahana and Srinivas. We are all on the behalf of IAP Delhi and on behalf of Dr. Jalil and Dr. Balachandran. I thank Dr. Sahana for a wonderful presentation. Most of the doubts were cleared. We had a lot of good discussion.
Thank you, sir.
Thank you very much.
Thank you, madam, for your.
Thank you so much, sir.
For sparing the Sunday time. Ajay Kumar sir, Alok Bandari and Mukesh, thank you.